Good morning, everybody. This is Dr. Shivam Mittal, and I have a pleasure to speak in front of you on advanced Parkinson's disease management. I want to thank the organizers to giving me this opportunity to talk on this very, very important topic. So I will start with a very basic slide on advanced Parkinson's disease and take you through the journey of Parkinson's disease patients. This is a very vast topic. So 30 minutes, it's very difficult to finish the talk in 30 minutes, but we'll try my level best. So Dr. Poonami already talked about early Parkinson's disease, the pre-motor symptoms, the early Parkinson's, and then you have the advanced Parkinson's disease. When we have the motor features of slowness in movement, stiffness in the muscles, and tremor, we call that as Parkinson's disease, Parkinsonism. We start the phase of early Parkinson's, and this gradually progresses over the years, and we see the late stage of these symptoms such as falls, balance issues, swallowing difficulties, gait freezing, and you have the treatment. You start them at patients on levodopa medications and other dopamine agonists, other medications, and you see some complications from the medications with the overall the long-term condition, and you see the symptoms of fluctuations, dyskinesias, freezing episodes, and this is what we call as complications or dyskinesias related to levodopa medication. And this is in advanced stage, it leads to psychosis, visual hallucinations, and other big problems which are very difficult to manage in day-to-day life. On top of these motor features, we always have underlying non-motor symptoms which play a crucial role in quality of life of these patients, which are symptoms of constipation, anosmia, REM behavior disorder, fatigue, memory problems, bladder symptoms, and I will come to that in details in one of the last slides. When we start the treatment for Parkinson's disease patients, we start with a variety of medications, including MAO-B inhibitors, dopamine agonists, levodopa medications. And as time passes by, we have to have more and more medications to manage their symptoms. And you can see in this area that there are many medications which we have to play with to help control the symptoms with advanced Parkinson's disease. So I usually say that when you start the medication, the patient respond very well, and that is a honeymoon phase where the patients are doing excellent. And after 4 or 5 years, or after 7 to 10 years, depending on their progression rate, you see that they start developing complications, fluctuations, and other symptoms, and you have to do really manage with multiple medications or cut down the medications to uh, have a better quality of life for the patients. These are the motor fluctuations that we usually deal in a day-to-day practice, mostly with dyskinesias, wearing off, unpredictable on and off. When the patient takes a medicine, the dose doesn't kick in. And many times the patient will tell that after I take the medicine and as the medication is wearing off, I have worsening of my tremor. Patients will commonly have non-motor fluctuations as well. And sometimes a patient can have peak dose akinesia. This is a review article where they looked at their patient sample size, and they found the most common fluctuations was actually the peak dose dyskinesia, but we see biphasic, off period, and multiple types of fluctuations. This is a diagram representing the journey of Parkinson's patient. Starting in the initial 4 years, we see a good years or the honeymoon phase I was talking about. Then after 4 to 5 years, patients develop motor fluctuations, and then you develop unpredictable off fluctuations or dose failures, and things become complicated as patients approach advanced Parkinson's disease or late Parkinson's disease. This is a good way to judge how the levodopa is working for the patient. And we classify as like stages in stage 5. Stage 1 is patient is not aware of any effect of the individual dose. So they are doing very well throughout the day. They don't feel any on and off. And second stage is they feel in the afternoon they're losing effect, mostly because of lack of absorption, because of heavy protein meal that can interfere with the absorption of the medication. And loss of sleep benefit, early morning akinesia, foot dystonia, these are other off state symptoms. And then the patients develop the classical wearing of motor fluctuations and abrupt on and off unpredictable dose response. And these are the different stages. Non-motor symptoms are very important when we talk about when we talk to our patients with regards to how is your tremor, stiffness, slowness. We also have to ask about how is the mood, anxiety, any low mood symptoms, feeling any panic attacks, tired, lack of like too much sweating, or flushing episodes. Many times in the off phase, patients will have more bladder symptoms, and they do better when the levodopa is working better. Dysphagia is also a very common symptom that you can see becoming worse in the off state and responds quite well to the levodopa medication. Pain is the other symptom which responds quite well if it's related to Parkinson's disease condition. And easy way to say the pain is because of Parkinson's or something other cause is looking at the response with the levodopa medication. And the most common reason for these fluctuations, we know that there's a peripheral cause and central cause. I will not go into the details, but the most important discussion here will be the gastric absorption. That's a key for what we can do clinically in our how to manage these patients better. We know there's a delayed gastric emptying and there's a lack of absorption, and how we can optimize the levodopa absorption as it reaches the brain to provide a sustained supply, to have a continuous dopaminergic uh, therapy. And you can see this is a very interesting photograph where it's a gastric mucosa. So this patient was scheduled for a Duopa pump, and patient took a Cinemet levodopa carbidopa medication 2 hours before the procedure, and the patient still had the Cinemet lying undissolved in the gastric, in the pylorus region, and the actual absorption takes place in the small intestine. So it still has a long way to go, and you can see that's why the patient has no response. He already waited for 2 hours. So this delayed gastric emptying plays a major role in and it causing motor fluctuations in advanced Parkinson's disease patients. So, what are the different ways that we can work around the stomach? You can give the medication in liquid formulation. You can give a transdermal patch. You can give a subcutaneous injection. You can give you can put a tube directly to the small intestine and deliver the medications through that, or you can do more central action like a deep brain stimulation. So there are several ways that you can work around, and this cartoon depicts very well what are the different options that are available for treatment of advanced Parkinson's disease patients. Now, coming to the levodopa, Dr. Poonami already mentioned about the treatment options for Parkinson's disease, and very effective treatment is the Cinemet or the levodopa carbidopa, or in UK, Germany, we have Medopar, which is levodopa and benzerizide. And we know that with over the years, after 4 or 5 years, the patients start having fluctuations. They can have dyskinesias or they can have wearing off. And in that state, you need to find out some other way to extend the effect of the medication. We do have Stalevo, which is a combination of Cinemet along with entecapone or COMT inhibitors, but we know that it is not always helpful, and we need something else to help them to control the symptoms better. There are new formulations coming up, like the accordion pill, where the medication is folded into sheets and it is inside a capsule. So it is released in a slow fashion. And then there is a subcutaneous levodopa carbidopa coming in future. And we also have the inhaled levodopa inhalation, which is called the Inbrinja. And we have a longer acting COMT inhibitors, which is called opicapone or Gentis. We have a newer MAO-B inhibitor, which with extra glutaminergic action, which is a Xerago or safinamide. There's a sublingual epimorphine, which is coming into action soon. And there are many medications which are coming on the way. And I think we are so desperate at this point when we see the patients in the clinic, that any option that can improve the quality of life or can improve the off phase, and it should be used as soon as possible. So these are the new options coming up, and some options which are already available. Now, coming to this very important concept of continuous dopaminergic stimulation, and the main three therapies are deep brain stimulation, the Duopa pump, and the Epimorphine pump. First, talking about deep brain stimulation, and many people, I think most of the neurologists are aware of deep brain stimulation, and because this has been there for more than 2 decades, we have gotten better in the therapy for DBS. We know in and out what are the complications to look out for, what are the ways we can do for the programming to improve the symptoms, and we also know when not to do DBS. That is a very important concept. So whenever we see a patient with Parkinson's and we think about DBS, the first three things are: is the patient really eligible for DBS? And if yes, then the patient needs a lot of further investigation, such as neuropsych testing, uh, physical therapy evaluation, speech therapy evaluation, a lot of counseling before we really go for the DBS surgery, because it is a commitment. And the symptoms that improves with DBS, as we are aware, are the tremor, the bradykinesia, rigidity, dyskinesia, and the motor fluctuations. The symptoms which do not get better from DBS are the swallowing difficulties, the balance issues, the cognitive dysfunction, and dysautonomia. It is very important because this is a very common question asked in the clinic, that doctor, I'm having a lot of falls, and I'm having a lot of memory issues, or my blood pressure is falling too much when I'm standing. Will this get better with DBS? The answer is no. If I see a patient who is having all of these symptoms, I would certainly take off the list from the DBS and do with medical management or the pump therapies to help their symptom control. The targets for DBS is subthalamic nucleus and globus pallidus interna. And this was a landmark study, initial study, where they found DBS was helpful in Parkinson's disease patients. And you can see here in this column that the number of hours improved, which was the on phase without dyskinesia, from 3 to 7.6 hours. The sleeping was much better. The immobile state was better significantly. It reduced. So these are some significant changes that the study proved. Also, there are other things like quality of life, emotional well-being, stigma, cognition. These all symptoms had a good improvement, but most of the motor symptoms showed a drastic improvement after DBS. DBS, always we have to look at a patient as a team approach. There has to be a movement disorder neurologist 24/7 available for the patient. There has to be a functional neurosurgeon who is in house for any troubleshoot. You should have a psychologist, psychiatrist, anesthesia trained in DBS surgery, speech therapist trained in LSVT therapies, physical therapy as well. Set up for DBS. And these are different devices which are available. We have three companies, which is Boston Scientific, St. Jude, Abbott, and Medtronic. And we have all the programmers which are available. The Medtronic recently came with a new programmer, which is available as well. And so that's DBS. We'll come to some patients at the end of the talk, but I want to discuss all the advanced therapies first. The second therapy I talk to all my patients, and we must know about this, is the Duopa pump. Duopa pump is innovative, is a very natural way of giving dopamine to the body. So there is a pump which is attached to a cartridge, and this cartridge has a liquid levodopa, and in a gel form, and not liquid, but it's in gel form. And this is attached to a tube. The patient has a PEG tube inside, and through the PEG tube, there's a further connection goes down to the jejunum. So we have a PEG J tube, and through this tube, the gel form of levodopa is transfused continuously during the daytime. And the absorption is direct to the small intestine. It is very fast absorption. The hope is that the fluctuations will be better. Again, we have not reached that stage with any advanced therapies that we are 100% sure that the curve will be flat. We will not see fluctuations. But again, there's still scope for improvement, and this is the closest that we can get at this point. This is a initial study from Cleveland Clinic Ohio group, and with a multicentric trial, and they showed that there was significant improvement by 4.8 hours. You can see there's improvement in on time and reduction of off phase by 4 hours. What's remarkable is around 92% patients had problems with the pump, and around 35% patients had complication with the device insertion because it's a PEG-J tube, and it becomes a hassle for these patients because of abdominal pain, procedural pain, nausea, post-operative granulation tissue or secretion. So you need to have a gastroenterologist who is really involved to follow up with these patients as well. This is the results of the multicentric clinical trial where they found the 2 hours on was increased and 2 hours off was improved. These are the other long-term studies. They have found that around 41% patients have complications with the device insertion. Around 36% patients have abdominal pain. So you need to tell this to our patients, and they should be aware that these are the common complications. These are very common. Anything more than 10% is common. If you say 41% patients will have device complications or insertions, they should be aware of that. So they are ready, and we have a gastroenterologist identified who can take care of this if needed. And this is another slide where they've summarized, and we can see 54% required jejunal tube replacement. That's also a big thing for the Duopa pump. Now coming to the third option, which is the epimorphine pump. And coming to epimorphine, epimorphine is one of the oldest medications, actually. It's a dopamine agonist, and it works as good as levodopa, Cinemet. This is one of the fastest acting and the most potent dopamine agonist. And its use was limited because of the nausea side effects. Now, with this formulation, I think we can get away with that with some priming with some prokinetic drugs like domperidone that really helps for the first few days when you give this medication. And epimorphine can be given by like an injection, like a subcutaneous needle, like an insulin needle. It can be also given as a continuous subcutaneous infusion, which is called the Epimorphine Pump or Epogo Pump or D-Mind Pump. There are two companies which make it, or maybe there are more companies. And the way the Epimorphine Pen works, it works very quickly. The absorption is much faster. It's more reliable. And the side effects are mostly yawning, sleepiness, nausea is a very common side effect with epimorphine. Now, the epimorphine pump infusion was proven with the study Toledo trial, where they had 53 patients, and they found significant improvement in the on phase and the off phase, and overall the dyskinesias were much better. The common adverse events you can see is mostly when you put the injection is an infusion site. You can develop nodules, you can develop some erythema. So that is something to be to observe and ask the patient to switch from one side to the other side or different location to avoid the skin induration. Nausea is a common side effect, but usually it goes away with time. Also, you have to treat the patients with domperidone for the first few days so that the nausea gets better. Now, the question is which therapy you should choose for our patient. So if we have a younger patient who has a lot of tremor, a lot of motor fluctuations, dyskinesias, the best option will be DBS. If the patient has depression, psychosis, mild dementia, then you start thinking about levodopa pump or the epimorphine pump. If the patient has contraindications for brain surgery, definitely you have to think about the pump therapies. If the patient has history of abdominal surgery, has contraindications to abdominal surgery, we don't have Duopa pump as an option. You go with the Epigo pump. If the patient has very bothersome dyskinesias to dopamine therapy, we know that Duopa pump will not work. DBS is the best option, or maybe we can try Epimorphine pump as well. Now, this is just a summary that you can make a note that every patient who is younger patient who has a lot of tremor, motor fluctuations, dyskinesias, think about DBS. The patient should not have significant cognitive, psychological issues, should not have any falls in the on phase, should still have a good posture control. These are some symptoms and signs you should always look out for patients going for DBS surgery. Duopa pump, epimorphine pump, mostly elderly, frail patients who cannot get DBS surgeries, and it works very well. I would say that epimorphine pump and Duopa pump are excellent treatment options for the patients who cannot get DBS. And mostly it gets difficult when you tell the patient about the PEG tube and the PEG-J insertion. They get a bit anxious because no one wants a tube or a gastrostomy. But again, you have to tell them there's a natural way of giving dopamine directly into the intestine, and I think it's a great option for advanced Parkinson's disease patients. And so epimorphine works subcutaneously, so it is much easier than the Duopa pump. Now we'll go through some examples. You're in your clinic and you see a 65-year-old male who has 14 years history of Parkinson's disease. And he mentions that he was doing very well for the past many years, but in the past 6 months to 1 year, he is noticing that he is having fluctuations. In the afternoon time, he takes food and he does not have any effect of the medication. He is having wearing off. And he also has some dyskinesias, which his family has noted, but he is not concerned about it. And so you realize this patient is edging from early Parkinson's towards advanced Parkinson's disease with motor fluctuations at this point. There are dyskinesias, there are off states, and then you optimize the medication. You tell the patient to take medicine on empty stomach for better absorption. You can add entacapone. You can switch Cinemet to Stalevo. You can add dopamine agonist, long acting. You can consider adding medication like safinamide, or if you have opicapone, you can consider that. These are the various options that you can consider in this patient. So this is what the patient is having. What I usually ask my patients to make a diary of the symptoms, and they can time it, and we know when the medicine is working or when the medicine is not working. And you can see clearly that the patient took his medication at 8 a.m., 12 p.m., 4 p.m., and 8 p.m. And you can see that at 12 p.m., there is no effect of the medicine because there's a dose failure. The dose failure is likely because he had lunch at noon, and that affect the absorption, and he's having more fall during this time. In the evening, he is having too much medication and he's having dyskinesia. So that is something to look into. Now, coming to a patient who has a tremor, who is an elderly man, around 58-year-old, who has a lot of tremor for past 6 years. He takes high dose of dopamine medications, but his tremor is not under control. So what option would you consider in this patient? We can go with DBS, we can go with focused ultrasound ablation, or we can do Botox treatment for hand tremor. So this patient went for DBS at Cleveland Clinic, Abu Dhabi. You can see this is the intra-op video. So you can see the tremor of his right hand while he is holding the cup. While we do the stimulation, the patient is awake during the surgery, and we can monitor behind the plastic is Dr. Tanmoy, who is a functional neurosurgeon, and that's me and the interpreter standing on this side. And with the stimulation on, you can see that the tremor subsides. So we know the target is right, and we proceed with closing the DBS lead. This is the in the clinic his programming. So this the DBS is off right now.
Hold your hands up like
You
this.
can see a lot of tremor in his hands. So the re-emergent tremor, and then here's a right hand rest tremor. A lot of bradykinesia, and you can see the right leg tremor coming up now. Now this is after the device was switched on. Keep your feet in the forward. So he's counting. And you can see the tremor is very nicely controlled with the stimulation. So other option is botulinum toxin injection. So this is the only randomized double-blind placebo-controlled study that we did when I was in US at Yale University, and this is it's a very good study where you find that botulinum toxin can be offered to the patients who have refractory rest tremor, which doesn't respond to levodopa medications and who cannot go for DBS surgery. So you can look at this video where this patient had a prominent tremor, and he got Botox injection in his right hand, and you can see the tremor is better now. And this is 3 months follow-up where you can see the tremor is coming back. So we know that the Botox works only for 3 months and the effect wears off after that. This is another patient who's around 85-year-old man who has a prominent left hand rest tremor with tremor dominant Parkinson's disease. And this is after the botulinum toxin injection. You can see the left hand tremor is under significant control. It's not 100%, but it is much better. I'm asking him to count backwards, and now you can see the left hand tremor starts surfacing. You can also use botulinum toxin for PISA syndrome, where you have truncal flexion towards one side. And okay, now another case we will discuss. So this patient is a young man who has a young onset Parkinson's disease. He has Parkinson's for the past 10 years. His chief complaint is right hand rest tremor. And when he takes a medicine, even 50 milligram of levodopa, he has severe dyskinesias. So this is his off state when he does not take any medication. You can see prominent right hand rest tremor, prominent bradykinesia with the right upper limb. I know it is difficult. It's difficult for him, and then he's a prominent rest tremor. He is reading Quran. That helps him to bring out the tremor, to concentrate more. Postural tremor as well. His gait, you can see right hand resting tremor. And now this is when he took the medication. So after levodopa, you can see he has prominent dyskinesia in right upper limb and right lower limb. You can see prominent dyskinesia there. So you can see a prominent rest tremor in this video and dyskinesia in this video. So he would always swing between the two phases, and he had no phase where the tremor is under control or dyskinesia is under control. For him, the option includes only DBS surgery because we cannot do Epimorphine Pump or Duopa Pump because he is so young and he has severe dyskinesia. So he would have the same dyskinesia with other two options as well. So the only option for him was deep brain stimulation. In the OR, you can see that he has prominent right hand and right leg rest tremor. I'll make it, I forward the video a bit. You can see I'm asking him to hold it up. Act as if you're drinking water.
حاول كأنك بتشرب مي من كوباية.
Now bring it out for me.
رجعها.
Abu Dhabi. This is right, but
الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
لان فيها ميه وقاعد بتشرب منها. ايدك لقدام يا راشد، حاول تمسك من.
Can you bring it out?
رجعها تاني للدكتور.
One more time.
كمان مره.
Very good.
رجعها تاني للدكتور.
Rashid, are you happy?
ايه رايك في النتيجه؟
So he corrects it.
شربت ماء كثير.
نعم.
شربت ماء كثير.
You drank a lot of water.
Now this is in the programming, in the clinic visit when we are doing the DBS programming for him. So we switch the DBS device, make the perfect settings. You can see the tremor is under very good control. His walking is not better. So this is
Close your eyes.
same patient but different video, different day of programming. Okay, now we come to the next case where this is a 49-year-old male who has Parkinson's for more than 10 years, and he takes medications every 2.5 to 3 hours. The problem with him is when he takes the medicine, it causes severe side effects such as nausea, vomiting. He lost more than 30 kgs, and you look at him, he's very frail. And he was pretty muscular and a heavy guy earlier, but he lost all his weight because of the side effects of the medication. But he cannot stop the medication because he is not able to move without the medication. So he has to take the Cinemet every 3 hours. So the good option for him is only DBS, because the Duopa Pump is again the same dopamine, and epimorphine can also cause a lot of nausea side effect as well. So we did a levodopa challenge. You can see a significant improvement in his UPDRS score from 39 to 6, and he had a DBS done, and he is doing very well. We have cut down his medication by 75%, and he is 85% better, or he is just taking medicine because he feels a need to take it. Otherwise, his motor symptoms are all under good control. That's his DBS leads. Now, other patient we'll talk about is, so we're done with the DBS. Now we'll move to the pump therapies with some patient examples here. Elderly man with prominent motor fluctuations comes to your clinic. He says, so this patient already had DBS done around 15 years ago. And he comes to see me. He says that he has prominent gait freezing. He takes a levodopa, Cinemet, even 2 tablets, 3 tablets. There is no improvement in the gait. And what do we do at this point? I made a lot of changes in the DBS, but the gait freezing is something which is not getting better. His overall upper limb appendicular symptoms are all under control. Good tone, no tremor control, doing very well with that regards. But mostly with the gait freezing is a big problem. So we did an epimorphine response test. So you can see this video where he is having significant shuffling of gait, gait freezing, not able to lift his leg up. Walking very slowly. He had a lot of falls because of the freezing. One trick is to always try for visual cues in this patient and see they improve or not. So you can see he can take a step very easily after you keep a pen in front of his foot. So that is a visual cues for gait freezing. And we did an epimorphine response test, and you can see that now he is very quick to stand up and he is able to walk so well. The gait freezing just improved significantly. So he now got his epimorphine pump and he is doing well. So we'll discuss another case where we have advanced Parkinson's with motor fluctuations, a 70-year-old man with a 15-year history of Parkinson's, and he is referred for tremor in his hands. He had a lot of dyskinesias and then wearing off, and he developed he had severe off and on freezing as a major cause for falls, and the fall was a major concern for this patient. And there are many options that we can do for these patients with motor fluctuations. We know he is elderly, we cannot do DBS, We know that he is having a lot of falls and balance issues. So best option for him will be something like Duopa Pump or Epimorphine Pump, depending on the response test, how much he improves with that. So this is something that we should always consider in advanced Parkinson's disease patients. Now, this is something which we see very often in our busy movement disorders clinic, which is patients coming with more than 10, 15 years of history of Parkinson's disease, elderly people. They have hallucinations, sleepiness, leg edema, irritability, falls, freezing of gait, bladder frequency, urgency, severe constipation, a lot of symptoms. And at that point, you look at the polypharmacy, what medications they are on. Are they taking chimedrin? Are they on anticholinergics? Any anti-neuroleptics medications, prokinetic agents, all these have to be looked into. Symptomatic management of non-motor symptoms is very crucial in these patients, looking at REM behavior disorder, fragmented sleep, vivid dreams, excessive daytime sleepiness, restless leg syndrome, dementia, depression, anxiety symptoms, apathy, orthostatic hypotension, siluria, constipation, erectile dysfunction, hallucination, psychosis, impulse control disorders, and many more. So it takes at least 1 hour to review all these symptoms and go through their history for any new patient Parkinson's. And I think its follow-up, it never becomes shorter. It always becomes longer because their symptoms changes with time, and you always have to understand and have to go slow with these patients and the families. They're already they're already going through a lot with these patients. This is a recent publication that we had in collaboration with University of Washington and Mayo Clinic, where we have summarized all the perioperative management of Parkinson's disease patients. This is commonly that I see mostly in UAE as well, that Parkinson's patients, when they get admitted anywhere in the hospital, they have a lot of issues in management of their medications. They will have hallucinations, delirium, infections, pneumonia, aspiration, things like that. So this is a good paper to have a look. If you don't find it, you can you can contact me. I will be happy to send you a copy of the paper. I don't think we have time for this bonus case. And this is our team, and I'm thankful to my team. We have Dr. Monsi with me as a movement disorder neurologist, Dr. Tarmoy Maiti and his colleague, Dr. Carlos, in functional neurosurgery team. We have a neuropsychologist, we have a psychologist and a psychiatrist, wonderful team of rehab specialists we have. And Parkinson's management is not a single person show. It has to be a team effort. And I'm thankful to everybody, along with my nurses and support staff. Thank you.